Good evening, ladies and gentlemen, and welcome to the Ohio State University College of Medicine Benjamin Rush Institute's second annual Arthur N. Roop Foundation's debate, hosted in cooperation tonight with the OSU Center for Bioethics and Medical Humanities. My name is Joe Myers. I'm a member of Benjamin Rush here at COM. Before we begin, if you have not done so yet, or if you did so previously to us having to reset the turning point question, please vote. We ask that you keep your clickers with you throughout the debate. At the end of the debate, there will be another short survey. We are pleased to have you here with us this evening, and we want to thank you all for giving up some of your valuable time. We hope that you find tonight an exciting discussion. We think that it promises to be just that, on the sale of human organs for transplantation. We want to thank all the students in attendance, as well as the faculty, staff, and administration from the College of Medicine and from the Wexner Medical Center and from Nationwide Children's Hospital. We want to thank and welcome all those coming from outside the medical center and medical college as well as all of those joining us via live stream throughout the country. Welcome. We want to thank our generous sponsors, the Arthur N. Roop Foundation and the National Benjamin Rush Institute, for their contributions that help make the event possible. We'd like to thank the Ohio State University College of Medicine for graciously allowing us to host this event here, as well as for developing a culture of learning and an atmosphere where open discussion and the free exchange of ideas is not only tolerated but encouraged. We would like to extend a special thanks to our Benjamin Rush National Director, Dr. Beth Haynes, for her advice and guidance in helping us with each step of the process to organize the event. We would like to thank the Center for Bioethics and Medical Humanities, Dr. Nash for his guidance, and he's pivotal in putting this all together, as well as Kelly Bolt, who helped us a lot. Finally, we'd like to thank our distinguished panelists, who we will be introducing very shortly. I'm going to talk a little bit about Benjamin Rush. As many of you know, Benjamin Rush was an American patriot and a physician who signed the Declaration of Independence. In keeping with that tradition, we aim to help expose those who work in the healthcare field, especially budding young physicians, to expose them to a broader spectrum of ideas than what they may otherwise be exposed to, concerning issues surrounding healthcare and the practices, or in the practice of medicine in the United States, with the hope that they will develop into not only fantastic caretakers, but well-informed citizens and leaders within their community as well. Our organization is primarily comprised of soon-to-be physicians from politically and culturally diverse backgrounds who have a common goal of being committed to solving healthcare challenges through innovation, abundance, and an inviolate doctor-patient relationship. Specifically here at COM, we hope to live out that commitment by holding such events as this one tonight. Our national organization and this chapter believe that a healthy, open, and honest exchange of ideas is the best way to achieve workable solutions to the problems that we face. So without further ado, I'd like to introduce to you Dr. Nash. Dr. Nash has a strong background in ethics and palliative care, researching how medicine, moral philosophy, and moral theology impact patients with advanced and serious illness. In addition to his leadership position in bioethics, Dr. Nash is the Hagop S. Makjan MD Chair in Medical Ethics and Professionalism, and he has a faculty appointment in the Department of Internal Medicine with an ongoing clinical work in the Department of Palliative Medicine. Dr. Nash is certified by the American Board of Internal Medicine and in Hospice and Palliative Medicine. Dr. Nash has repeatedly been named to America's Best Doctors and World's Best Doctors list. Here's Dr. Nash.
Thank you. Thank you all for coming, and I really have a great deal of gratitude towards the Benjamin Rush Institute and the Arthur N. Rupp Foundation for sponsoring this debate. We're happy to be partners with them at the Center for Bioethics and Medical Humanities. I also give a great thanks to the student leadership, Joseph and all the other students. This is a student initiative, this is a student group. They came up with the topic, they came up with who to invite, and they partnered with us. It's really wonderful, though we've been helping guiding. It's so easy to guide people with so much enthusiasm and so much zeal for a topic. It's really wonderful, so I applaud them for making this happen. This is the second annual Benjamin Rush Institute and Arthur N. Rupp Foundation debate. Last year was a great success. I hope this one is too, and I hope this is starts a long history of these debates here at the OSU. And I have expressed my interest in the Center for Bioethics and Medical Humanities, being a longtime partner in that. So I really congratulate the students and job well done. The task today is we're engaging one great ethical dilemma. The Center for Bioethics and Medical Humanities and debate forums like this try to enter into a dialogue on issues that sometimes bring hostility and emotion and conflict. Sometimes we are forced to deal with dilemmas and questions that in polite society we just don't talk about but probably should. So debate forums like this give an opportunity for a respectful, informative dialogue in a debate, so we admit at the beginning that there's a disagreement. And then we enter into a respectful dialogue to try to come for at least better understanding, and I think both would like to convince you. Therefore, the debate format actually asks you to make a decision. You must choose which side you stand on, and at the end, you'll be asked again, have you changed your mind or not? So it admits one central theme, it admits something very scandalous, that we don't necessarily agree. And then we can enter into respectful dialogue to, again, gain better understanding and even maybe be swayed to to a new position. We have two really excellent speakers and debate partners today. Again, I mentioned if you haven't voted, please do. Even if you voted early, they had to reset things, so vote again. Don't worry, it won't be counted twice. The ticker won't let you. And you will be voting at the end. So we have two excellent debate partners today. The first is Professor Mark Cherry, who is the Dr. Patricia A. Hayes Professor in Applied Ethics and Professor of Philosophy at St. Edward's University in Austin, Texas. He earned his undergraduate degree in philosophy from the University of Houston and his doctorate degree in philosophy from Rice University in Houston, Texas as well. His research encompasses ethics and bioethics together with social and political philosophy. He's editor of the Journal of Medicine and Philosophy, associate senior editor of Christian Bioethics, published by Oxford University, and editor-in-chief of Healthcare Ethics Committee Forum, published by Springer. He is co-editor of the book series The Annals of Bioethics and editor of the book series Philosophical Studies in Contemporary Culture. He's published numerous books, articles, book chapters, and other publications, including a book on the topic of today's debate. I think it gets one of the best titles and covers known. The book is Kidney for Sale by Owner: Human Organs, Transplantation, and the Market. Professor Cherry will be arguing on affirmative on the statement that frames our debate. His debate partner is a proud member of the Ohio State University Center for Bioethics and Medical Humanities, amongst her many other roles. Dr. Amy Pope-Harmon is an associate professor of clinical medicine in the Division of Pulmonary and Critical Care at The Ohio State University. She received a BS in psychology and MD from The Ohio State University. Her residency in internal medicine was followed by an additional fellowship in pulmonary and critical care medicine, completed at The Ohio State University Medical Center. During the final year of her fellowship, she obtained special training in pulmonary transplantation at the University of Pittsburgh. Following her return from Pittsburgh, she served as the Department of Internal Medicine Chief Medical Resident here at the OSU. In that year, she began she furthered a great interest in medical ethics. She began serving on the OSU Medical Center Bioethics Committee, and that committee she chaired for over 10 years. Dr. Pope-Harmon's primary clinical interests and duties are in the area of pulmonary transplantation and late-stage lung diseases, as well as intensive care medicine. She has lectured extensively on ethics, with topics ranging from the ethics of technical advances in medicine to transplant ethics to palliative care. She has publications on topics including lung transplantation and pulmonary diseases. I think the debate's going to be an exciting one. We're not afraid to sit these two so close together, because you can't have more joyful, kind debate partners. These are really two wonderful people. Though I hope they disagree, so we have a good debate. There's going to be a format to this debate, and I, as the moderator, have to be aggressive and enforce it. There will be opening words, which are now ending. Then there's going to be an opening statement from Professor Cherry, followed by a 3-minute rebuttal by Professor Pope-Harmon, then a rebuttal to the rebuttal, and then we'll switch places. So there's going to be a structure to the debate so we can try to get at issues in some depth. Then after both have had their time, I'll try to lead with some questions, and then after, at about 7:30, it's going to turn to you. So please think of your questions. There'll be several microphones throughout, so please think of your questions. I ask you that you limit your questions to 2 minutes, so don't write a treatise. We can begin now. Professor Cherry, we would love to hear your thoughts on organ markets and organ transplantation, organ procurement, etc. Thank you.
Ladies and gentlemen, it's a great joy to be here with you in Ohio, visiting from the Republic of Texas. Let me give my thanks to Professor Nash for having me up here, as well as the Benjamin Rush Institute, and to you, ladies and gentlemen, for giving us your Thursday evening. I think I'm supposed to push the voting, and as we say in Texas, vote early, vote often, and frequently.
Repeatedly.
There's surely more clickers than there are people. That would solve that problem. At any rate, we were just having a private conversation up here before I start about this issue of debate partners. That doesn't sound particularly adversarial. So we were thinking debate adversaries, yes. Debate enemies, debate... and she tells me she's not carrying a scalpel, so probably we're fine. What I'd like to do is start out with the following sort of a fantasy. I want you to imagine two individuals. I want you to imagine Ryan and Sarah. Okay? And Ryan and Sarah have both agreed to donate a kidney to save the life of a child of a close friend. Both Ryan and Sarah are enjoying the recognition that comes with saving a life, risking their health at least somewhat, so as to try to save the life of another. They're pleased with sort of the heroism of their activity, and are really looking forward to saving lives. Now, Ryan is giving his kidney away totally and completely for free, but Sarah has asked the mother of the young lady that she's going to save to provide her with a scholarship to Ohio State University Medical School, which the mother is very happy to pay. She's only too happy to reward the person who is saving the life of her daughter. What's the moral difference between Ryan and Sarah, if any? While you puzzle about that, think about paid rescue workers and other facets of our lives. We have firefighters who earn a living fighting fires. It's a dangerous job. We have police officers, we have Coast Guard naval rescuers, we have ski and rescue teams. All these groups risk life and personal injury to help others while collecting a salary. One may surely work as a volunteer firefighter. I have friends who that's what they do for fun on the side. It's sort of an aggressive thing to do, but they enjoy it. But those who make their living this way, are they any less heroic? Are they any less engaging in an important activity to save others? A surgeon can surely agree to provide surgery for free. That a surgeon charges for her services that does not reduce the value of the surgery. With regard to Ryan and Sarah, the organ retrieval surgery will be exactly the same. I'm not imagining a black market for Sarah. I'm imagining it happening at a first-class transplantation facility. The legal difference between the two cases, though, is really striking. Ryan's choice is praised, encouraged, and the subject of positive educational propaganda and legal. Sarah's request for compensation, however, is decried, denounced, defamed, and subject to legal punishment almost everywhere in the world. Why? That's the question. The prevailing moral viewpoint is that human organs may be donated, but they should not be sold despite the immense shortfall in organs available for transplantation, the consequent increase in human suffering, and the deaths of otherwise salvageable patients. Patients that we could save if we had access to more organs. They die because we don't engage in activities which are designed to incentivize access to organs. Commentators routinely moralistically opine that human organs should not be viewed as commodities to be sold for private gain, but rather somehow they should be treasured as a sort of altruistic gift, a social resource to be distributed according to medical criteria. Prohibitions on financial incentives for organ donation are often couched in very lofty, very moralistic terms. So if you turned to the Declaration of Istanbul from 2008, they say we need to preserve the nobility of organ donation. It's also subject to very manipulative educational campaigns. Give the gift of life. Right, designed to really try to engage people in this activity. Organ transplantation, it is claimed, should somehow transcend commercial practices and rise above marketplace morality. Yet, the challenge here is that the urgent public health issues due to the considerable disparity between the number of patients who can benefit from organ transplantation and the number of organs available for transplant will not be adequately addressed by the vilification of commodification and market transactions. Despite the fact that these assumptions underlie nearly all public policy regarding organ procurement and transplantation, my argument is that each is misguided and illegitimate. We should embrace instead market-based incentives for organ procurement to save lives, to reduce human suffering, all the while to help contain economic costs and to stretch healthcare budgets. Financial and other valuable incentives. You don't have to focus just on cash. Sometimes people are really bothered with cash. I'm pro-cash. I'm totally happy when people want to give me cash. But sometimes people are bothered by that. So imagine something different instead. I gave the example of a college scholarship. College scholarships are worth a lot of money. And yet they have long-term positive impact on individuals, insofar as you can shift people towards doing long-term goods with their lives, like college work. You can change their lives and the lives of the people around them. At my own university, my university provides college scholarships for every employee's child, whether they're staff or faculty, they sweep the floors or teach in the classrooms. Their children can come to the university for free. And it's an expensive private university. The university does this precisely because they know it changes lives. It's a long-term goal to change lives. We could use that same incentive to incentivize access to organs for transplantation. Could use tax incentives also. There's lots of opportunities here to encourage living persons to donate redundant internal organs, kidney, for example. You could use it to increase access to non-redundant organs, such as the heart, with donors or their families granting permission for organ harvesting after death. The idea is to imagine that I'm driving home from my office in Texas. I have a long drive. Texas is a big place. And I get hit by a car. And I go to the hospital, and my wife comes in, and it's clear that I am terminal. And they approach her and they ask her, would he like to donate his organs? And my wife, being a good Texan and pro-market, says, no, but he'd be happy to sell anything that's useful. How much is he worth? And discovering that maybe I'm worth $500,000. She says, this is good. I can still afford to put the kids through college. I can pay off the mortgage. I don't have to go get a job right away. I can retrain. I can do all kinds of things to support the family because it turns out my husband, without ever telling me, had a very large life insurance policy, or the equivalent thereof, namely his organs, which we are going to use for transplantation. We save all these lives, and at the same time, we preserve resources for the family. What we do right now is we legislate altruism on the part of donors or the donor's family. We coerce self-sacrifice in otherwise commercial settings. Think through with me real quickly, who makes money on transplantation? Surgeons do their surgery for free, right? Okay. The anesthesiologists, they do it for free, right? The hospitals don't charge anything, right? The organ procurement agencies do this for free, right? UNOS is free. The only person or group of people who does not make money in this process is the donor or the donor's family. Everyone else is engaged in a commercial transaction. That coerces altruism in what's already a commercial setting. It requires a special sacrifice on the part of the donor that no one else is somehow subject to. However, at stake here is not solely the efficiency and the effectiveness of transplantation, but more fundamentally even is the recognition of the moral authority of persons over themselves. Imagine the following. What we do right now with regard to organ transplantation is we say, Mark Cherry, if he wants to, can donate a kidney to a relative, a family member, a friend, a total stranger, as long as I do it for free. What justifies that activity? That activity is justified by the thought that I am in authority over myself and my body, and I can give informed consent to the transplantation. I don't need the surgery. The surgery is done to benefit someone else. But notice, we affirm in that case the authority of persons over themselves to donate a kidney. At the same time, we deny the authority of persons over themselves to do all exactly the same thing if they accept money. So if I want to save someone's life by donating a kidney to them, but they want to give me in response $10,000, all of a sudden it's illegal, even though every medical aspect of the case is the same, including the authority of the person over himself. So what I'm arguing today is that openly embracing a market in human organs for transplantation would encourage virtuous tendencies in the transplantation world and would shed light on what's often a hazing and shrouding public policy setting, while better addressing the shortage in human organs for transplantation. I think we can do a better job. Some very quick background numbers. If we're going to realistically assess current transplantation policy, we must also consider the background risks involved in organ transplantation that is bereft of the significant valuable incentives of the commercial market. Right now, any organ that might be available with incentives is not currently available, and that has an impact on our system. So according to UNOS, as of May 9th, there were just over 133,000 people waiting for organ transplants. Now, it's a little bit inflated because individuals can be registered at different locations, and so it's slightly inflated above. That's a slightly inflated number, but not that much. In all of 2013, there were just over 28,000 transplants. So it's a far lower number If you look at the number of people who died while on the waiting list in 2013, it was almost 7,000 people. Just over 5,000 people were removed from the waiting list because they had gotten too sick to transplant. And as near as we can tell, there are other individuals who are dying without really us tracking them very well because they've been removed from the waiting list because they're just too sick to transplant. While the demand for organs continues to rise, organ donation rates in the United States has been relatively stagnant for some time. Organs are procured primarily from cadaver sources. However, living donation is constituting a greater, ever more significant portion of kidney donation, for example, and we're even getting some liver lobe donations, but that is a more dangerous procedure, as I'm sure the physicians could tell you better than I. In short, altruism-based policies have simply not been adequate to meet the medical need for transplantation. The usual circumstance now for transplantation without a private donor with regard to kidneys is an ever more significant wait, and often an ever more significant risk of dying. UNOS reports, for example, with regard to kidney transplant, that those with blood type O who registered in the 2003-2004 year experienced a median wait time of 1,851 days. Those with blood type B experienced a median waiting time of 1,935 days. Given the increased demand for human organs and a concurrently increased queuing time, the median wait time for patients with less common blood types and highly sensitized recipients has often become very difficult accurately to calculate because fewer patients as a percentage of those queuing actually get transplanted. What my friends who work in kidney transplantation tell me is that even queuing for less than 6 months has a long-term negative impact on health risks relative to preemptive transplantation. What they tell me is that over time, the body becomes more fragile, creating a greater likelihood of poor post-transplant outcomes. So what happens is if the median wait time for kidney transplantation continues to increase, which seems likely, it will surpass an ever greater number of those waiting for transplantation. Moreover, again, just focusing on kidney transplants for the moment, sustaining patients medically while they await transplantation is very expensive. Total Medicare costs, just looking at just Medicare costs, for end-stage renal disease in 2000 was just over $12 billion. By 2008, Medicare expenditures for end-stage renal disease had increased to over $23 billion, and it continues to increase. In 2008, the cost for patients on dialysis was just over $76,000 a year. In comparison, per person cost for transplant patients was just over $26,000. And if patients had a well-functioning graft, the cost was just over $19,000. What happens is for kidney transplants is that kidney transplantation, for all of the initial bolus of expense of the transplant surgeon and even the long-term cost of treating the transplant organ, becomes cost neutral after only about 12 to 13 months relative to continuing end-stage renal dialysis. So it actually saves money long-term. So insofar as waiting times for transplantation can be reduced through financial incentives for organ donation, these incentives would save lives and they'd also save money. So let's think here of a few examples how we might engage in this. When I teach this subject at my own university, I always ask my students at this point, I say, look, how many of you would be willing to donate a kidney in order to get out of college with exactly zero debt? Almost every hand goes up. Now, how many of them would actually show up, I don't know, but almost every hand goes up because they recognize the implications for their long-term future. They're often altruistically motivated since they would like to help someone else to save their lives, but at the same time they recognize how important being without debt is to their lives and how good the college education can be. And they see that as something that would motivate them. But imagine other examples. Think of a futures contract. You sign now, and what you say is at the time of my death, my body will be assessed, and whatever is available for selling will be sold, and the proceeds given to my wife, my children, my favorite charity. They go to the Daisy Hill Puppy Farm, Whatever the money goes, I decide. It goes to my assigns and heirs. At that point, we're not talking about harming an individual who's living. We're talking about somebody who sold something after their death. It's a futures contract. You could think, as I mentioned earlier, of deceased donors as having kind of like an insurance contract. My wife would love it if it turned out I was dead, that she got an extra bolus of money to try to figure out how to keep raising the kids. That would be really helpful for her. She might prefer, I've never asked, that I stay alive and earning. Seems like a bad question for a husband to ask. But I know for a fact she would like the additional income insofar as I'm not there. Knowing that families would financially benefit would very likely encourage many more potential donors to state their intentions to be organ donors. Financial and other market-based incentives encourage persons to raise resources to further your personal goals, to further your social interests. They drive technological and medical innovation, and they possess significant motivational force independent of civic-mindedness, self-sacrifice, and social solidarity. There's no reason why you can't keep talking about civic-mindedness, self-sacrifice, and social solidarity, but why not add something in addition? Right? My sons know that I'm pro-education. My sons know I want them to study and do well, and they do that. And I explain to them why studying really matters. But I also hang out the possibility of cash for good grades. My sons are young. They have no understanding of money. You don't have to offer them very much, and they get very motivated. Right? It matters. It shifts their behavior. It works also for larger populations for things like this. And again, if you find the idea of cash unduly crass, think of college scholarships. Think of paying for funeral expenses. Think of other kinds of incentives. We already have, as a matter of fact, a barter market in human organs. We don't talk in those terms. It seems to be crass. But we have barter markets in which we, in fact, exchange organs. They're called triple swaps. They had to actually go in and modify the law to make it legal to engage in a triple kidney swap, because the law specifically ruled out the receiving of anything of valuable interest. Well, getting a kidney early on is a valuable interest. So they adjusted it, and we now have a barter market in human organs. No reason why that is wrong. I'm in favor of that. That seems very plausible. Organ swaps seem plausible. These other kinds of things seem very useful ways of, in fact, engaging in incentivizing people towards donating organs for transplantation. I think my time is up.
Your time is up. Dr. Pope-Harmon, would you like to give a brief 3-minute response?
All right. I'm going to begin with an introduction and some disclosures. As a transplant pulmonologist and intensivist, I endorse and engage in the process of organ transplantation in the real world. I regard organ transplantation as a wonderful, nearly miraculous option for many of my patients who would otherwise die. I've had the sad experience of patients dying on the wait list, or of having been taken off the list because they become too ill and could no longer benefit from an organ transplant. To have to tell them, their families, that the organs did not come in time. I would very much like to have more organs to transplant. I would very much like to have other options than organ transplant for my patients in the form of scientific advances. I believe that most individuals are good, but some not so much. I believe that circumstances sometimes prompt people to do things they would otherwise not be proud of. I am neither a philosopher nor an economist. I am a human and a physician, a medical professional, and a participant in a society that is moderately generous in its offers for support for underprivileged, varying slightly depending on the prevailing political winds. Dr. Cherry has, over the years, built a tightly constructed, philosophically based argument for this type of a market. My arguments will not be philosophically polished, but will address most of Dr. Cherry's points in real-world observations. I honestly don't expect to directly overturn the hypotheses that we are presented with this evening, as skillfully framed by Dr. Cherry. I also do not expect necessarily to win a point-to-point comparison to Dr. Cherry's logic, but I do hope to bring a real-world understanding of why it is that most of you medical students are struggling, and most of you still have both of your kidneys and no extra cash in your pockets.
Any questions for him or a response? Professor Cherry, would you like to just 2 more minutes, and then we'll
Sure. Think about different ways in which people would like to advantage themselves. Again, I'll use the example of people at my own institution. I'm just an undergraduate philosophy professor. Many of my students come from very impoverished backgrounds. I know that many of my students have parents who are sweeping the floors and cleaning the bathrooms. The parents have taken on jobs which they understand are not the most attractive jobs. They took the job, though, because they were making a very rational choice. Because the fact that you're impoverished does not mean you can't make good choices. They understood, as I've talked to them, that their children would come to this university, my university, for free. And they understood it would change their lives forever and the lives of their grandchildren forever. So however much some of the individuals who are sweeping the floors and cleaning the bathrooms, doing other things, landscaping on campus, come from impoverished backgrounds, they still made very rational, very intelligent choices, which were really useful for their families. And my suggestion today is you think in those terms for how we might use a market-based incentive to help individuals do the same thing with regard to organ transplantation.
Thank you. Now, Amy, Dr. Pope-Harmon, you have the floor for 20 minutes to give more of a concise...
Very good. I'm going to be taking into account that everyone is, excuse me, a healthcare professional, or most everyone here, and has some understanding of organ donation, et cetera, but to do a little summary of exactly how it happens. First, most organ transplants come from deceased donors now. All hearts, pancreas, small bowels, they're all deceased donors. Essentially all livers and lungs, with the exception of the lobar transplants that Dr. Cherry was talking about. And about 2/3 to 3/4 of kidney transplants are from deceased donors. However, not all deceased patients can be donors. Only about 1% of people who die here in the United States or anywhere can be donors. It is essentially made up of brain-dead patients who have been neurologically injured and whose brains are permanently dysfunctional or permanently not able to function. And that is the most of the donors. There is also a category of neurologically devastated patients whose families have made the determination that they will come off of life support. This is called donation after circulatory death or donation after cardiac death. These donations or procurements are done in controlled circumstances where the patient is brought off of life support in a controlled setting in an OR, and then the organs are procured in very quick manner after that. There is also another category of donation that doesn't happen much here in the United States, and if it does, it's only under really experimental kind of circumstances, but does happen in the rest of the world, called uncontrolled donation after cardiac death. This is practiced a lot in countries where the presumption to be a donor is assumed, where there's a presumed consent to be an organ donor, and you would have to opt out not to be an organ donor. That's how it is practiced most commonly. So how is consent achieved at this point for dead donors? If you designate on your driver's license and are otherwise an already dead candidate, you're essentially willing your organs, your usable organs, to the local organ procurement agency. They can go through whatever means necessary to retrieve their property at that point. This is not viewed legally as a medical consent, and as you may have noticed when you review your driver's license, the people at the VMV are not really prepared to talk about that. If you consent on your driver's license, though, here in Ohio and in many states, this consent stands and would stand over any objections that your family might have. If you have not designated on your license, however, then consent can be sought from the family, and by federal mandate, by the rules of participation in Medicare, we actually, as a hospital system, have to provide access of designated requesters to families to be able to request donation, and those are often personnel or employees of local organ procurement agencies. Hospitals are also required to inform the local OPOs in a timely fashion and to establish and follow procedures for doing so in each hospital. So how do the organs get where they're going? After the consent is obtained, by the way, the Department of Health and Human Services target that 75% of eligible donors are consented, the OPO agency takes over care and management of the deceased patient. In the case of brain dead patients, they are maintained on the ventilator, stabilized, organ function assessed, and optimized. OPOs and, the Organ Procurement and Transplant Network, or OPTN, which is a federal entity, working via the United Network for Organ Sharing, sets about attempting to match the various organs with potential recipients, according to the waitlist entries on a national database. This process involves complex protocols, sophisticated communications, high-level input, and management on the part of the OPOs who keep comprehensive records, which they make available to the public. They facilitate safety measures such as ABO confirmations, help to package organs, sometimes maintain perfusion of organs outside the body, and arrange for transplantation of organ and/or organ procurement teams. This is really a huge deal and requires an amazingly complicated dance for each donor. Each OPO then sets a per organ price to the institution that will perform the transplant. They are not free, as Dr. Cherry mentioned. The price covers the operating expenses of the OPO and the network. This price is then transmitted in some way to the recipient and/or third-party payer. The whole process is under constant scrutiny and revision with input permitted and encouraged from agencies themselves, transplant professionals, donors, donor families, recipients, listees, and the public at large. And it was set up that way as well when it first started. Families are not compensated for agreeing to donate at this point. Now, what about living donors? The option for transplant is required to be presented for dialysis patients. And if it can be achieved on the whole, as Dr. Cherry said, is much better from a financial standpoint as well as from a survivorship standpoint for the patients. When under consideration for transplant, potential recipients are given the option of attempting to obtain an organ donor for transplant from a living donor, or an organ for transplant from a living donor. This generally will be a relative or someone that they know. Many people don't have someone they feel comfortable asking or don't have such a donor. Some have a willing donor, but they're not a good match. And there is also a program, as Dr. Cherry mentioned, through UNOS that offers paired donations or other types of chain donations. Donors are required to be extensively evaluated for sufficient renal function to offer sufficient reserve throughout the rest of their lives, for diseases that may later affect renal function or could harm the recipient, for general suitability for surgery, and psychologically to assure no undue influence and no psychological concerns. The expense of all that is charged to the eventual recipient of the organ. Direct living donations do not need to be arranged via UNOS, but are reported to a national database so they can be tracked. Living donors are also not compensated, but the medical care related to the donation is covered by the recipient. There is no direct compensation for time off work, etc. However, there is a federal donor relief fund that can be accessed for some for travel. Now, regarding whether there is consensus among the medical community regarding the state of organ markets, Dr. Cherry didn't specifically address this. However, transplant professionals are largely against the sale of organs, not because they are looking to be paid more or looking to cheat people out of being paid for their organs. This is more consensus than practically any other issue faced by a plurality of cultures, disciplines, background, and countries, although with some notable critics and exceptions. None of us want to do fewer transplants. None want transplant patients to die. Whether they express their arguments in philosophical terms, they do think through the implications of their recommendations, including the death of patients on the list. The very number of these governing bodies, many otherwise engaged in transplant, should be an indicator of the consensus. One would expect listees to likely think otherwise in their own interest. And surveys asking people if they would sell a kidney or trade a kidney for a college career, etc., can be dismissed, I think, because they do not have all the necessary information to make an informed decision regarding a donation or compensation. And there is no giant conspiracy to maintain control or profit. With many of our individual or government interactions, the upshots of which are often established before any conversation can take place before or until the complexities of time, habit, and et cetera preclude any real or sustainable change. In this case, the ethical community had the opportunity to weigh in up front. Of course, fashions and attitudes change over time, and we don't always ask the right questions in the moment, but we could debate the underpinnings of any number of controversial and complex relationships such as this one. Let's say you include any of those patients waiting for saleable organs, the redundant organs, several writers, and however many more may be in agreement. It's hardly not enough to break any reasonably tight consensus. There are only a few others who have put forth similar arguments. You'd think they'd be speaking up in the throng by now. So arguing against the fact or the thought that the government has no right to tell us to do with our own bodies. Governments do things all the time to limit people's freedom from doing themselves or others harm. We ask and allow the government to do just that all the time. Abuse of some drugs is illegal. Speed limits are set. There are prohibitions of jumping off and climbing tall things. We expect our government to protect us and have given them that task and responsibility, which for the most part we allow and accept. We expect them to oversee our food, drug supply, consumer products, workplace, and environment. Governments will do whatever we allow them to do, whether authority is based upon moral grounds or not. There is some expectation that either regular individuals or agents acting for the government would protect those who are potentially doing themselves harm if possible. Get the drunk person out of the car, don't serve additional alcohol, don't let the gal jump off the bridge. We have acquiesced as a society at times to conscription, which is supremely a bodily takeover. Governments have the responsibility to prevent burdens that the rest of society may come about as a result of commercial venues. However, they don't always do well with this. The government, meaning we all, pay for the restoration or maintenance of health in the form of a safety net, so that if you expect that, you must give up some control if you wish to have access in such a rescue. Regarding the question of whether governments should be involved in something so intimate as what happens to our bodily organs after we die, first off, there is no remotely reasonable way of having the good of organ transplantation occur without the general approval of a widely governing body. Whether you believe in government hands-off or not, you can't have it both ways. And secondly, it's been set up in such a way that it is government sanctioned and supported, intimately linked, yes, but is not the actual government in this country that is running the process as it stands. And we shouldn't sacrifice good for perfect. The assumption here is slightly different. It is one of facilitation of a widely viewed good thing rather than usurping. And this, of course, goes out the window when you go down the road of presumed consent that I talked about from other countries. That said, I've always had a little difficulty with the first-person consent. And while I'm grateful for the resource, I am still uncomfortable with the uninformed nature of the process, whether a gift or not. This is clearly a situation wherein the body is considered by the law a possession that we may arrange to distribute after our deaths, one with an intrinsic value and one with the government can claim at whatever cost, what could be potentially considered gruesome or even ruthless circumstances. Just because the problem is difficult and the current system less than ideal does not imply the basic premise is wrong, however. Regarding the argument that people should have the opportunity to better their lives through use of such organs, we are all about bettering our lives here at OSU. The reality is that an organ market is not likely to better the seller's lives. The amount of money, whatever it is, that one may receive for an organ is not going to help the seller for very long, and it's finite. You make a good argument for the college tuition, though. Most people, though, say in Canada that they would, or the majority of people who were surveyed in Canada several years ago said that they would sell a kidney for $10,000. That's a lot less and probably not very thoughtful response on their part. The organ market has not helped sellers in countries where organ markets have been permitted in the past. A study by Goyle came out in 2002 for persons who had sold kidneys in India. The majority after that were still in debt 6 years later. More were below the poverty line than prior to the time that they sold the organs. Greater than 80% of them had worse health than they started with, and some wives in those surveys reported that their husbands forced them to sell their kidneys. We know also that other one-offs, such as winning contests, lotteries, et cetera, do not result in people being better off for the long term, which is what it would mostly be. There are not going to be a lot of people who are heading to college looking to drop a kidney in order to be able to get there. Other situations wherein people sell body parts or parts of their body or health has not resulted in better circumstances for their sellers. Witness plasma sales, the sex trade, industrial revolution, mining, etc. Unfettered capitalism doesn't really have a good human rights track record. When one is selling the last tangible thing she has, an intrinsic part of the body, even if you can get along without it, she is by definition vulnerable, likely to get taken advantage of, and likely to end up no better off. There will be no windfall. The buyer is not going to give any more payment than they absolutely have to. They're not going to come through with $250,000. In this case, the seller may be worse off. With regard to the health, they're going to be down one kidney. The future health is in some jeopardy. There's less renal reserve. They're going to be in vulnerable financial situation, and they're not going to take that money that they get for their kidney and invest in the Affordable Health Care Act to be able to get insurance. They may not get good aftercare. They're coming with a cash motivation. They're going to be cut and run. They may have worse peri-procedural care, both because of the cost-cutting measures that may end up being inherent in the capitalistic market, and also perception by healthcare workers of the donor as a non-altruistic and cash-hungry person. With regard to finances, the sellers are likely to be at least no better off. They are going to remain vulnerable and in the same circumstance that led them to sell the kidney in the first place, and then they're going to have nothing of valuable left to sell except for maybe plasma and sex favors. And then there are psychologic consequences, self-esteem. The seller is vulnerable. What are they going to do when there's nothing left to sell? How do we know that such a person would be even able to take care of him or herself afterwards? Where do you draw the line? How much can you sell of a person? Who is going to take the responsibility for making up the global organ function deficit in all those out there with no renal, hepatic, or pulmonary reserve? And the option does nothing to sustain the person long-term, nothing to lessen whatever societal obligations we may accept to sustain that person. Perhaps, if anything, it increases the societal burdens, not to mention what type of obligation we may be under if the remaining organ fails or if the person dies or as a cause of the procedure. Other examples of legalization of the sale of other bodily assets has not gone well for the sellers. Witness legal prostitution. You don't even need to remove any part of the body permanently to do that. Prostitution fills a need, sure. One might argue nearly as sure a need as organ transplantation. However, one could argue as well that it's better when given with altruism or with affection. It certainly has not, whether legal or not, improved the circumstances of those selling their assets. If they were going to give college scholarships for prostitution, I'm sure it would have been done by now. It's been around for a long time. Where legal prostitution has done two things, perhaps. That's increased the safety for those buying the goods, those exploiting the sellers through STD testing and the like, and has increased the opportunity for more middlemen to insert themselves into for the purpose of making a profit. In this situation, it may be organ pimps. However well-intentioned these middlemen may initially appear to be, it will eventually be about the profit. This is already happening with altruistic, quote-unquote, donors coming out of the woodwork, coached to present themselves as cousins and the like. They may get a few bucks under the table, but the go-betweens make enough dough to make the illegal brokering worthwhile. If it turns out that we are imposing our Euro-American view that exchanging money for body parts is not morally or otherwise acceptable, this is one case in which I refuse to feel guilty about it.
Thank you. A brief rebuttal, 3 minutes from Professor Cherry.
Sure. I'll begin by saying, insofar as there are negative health consequences associated with organ transplantation for the donor, I'll grant them. I'm not a physician, but notice that's about donation. That's not about whether we buy and sell, whether there's financial incentives. That's about the fact that we're taking an organ from a person who's living and still needs to use it potentially and transplanting it to another. So if we're going to grant those parts of the debate, we should give up transplantation altogether. That seems to be something we're not willing to do, so the question is not then give up totally, but rather what kind of restraints do you need to put in place in order to do things responsibly? We shouldn't be thinking about black markets. I'll grant at once, illegal markets, bad. Hard to enforce contracts, or impossible to force contracts. How do you sue someone for malpractice in an illegal market? It's not happening. The idea is to imagine these things taking place at a major medical center, the Mayo Clinic. Right? All the usual issues associated with malpractice gear in. The hospital really cares that things are done properly, and we're engaging and tracking patients in a reasonable fashion. So unless we're willing to give up on transplantation altogether, it's unclear why we should think of those negative aspects as ruling out financial incentives. Second, with regard to consensus, there's an immense force of political pressure not to come out in favor of selling organs for profit or even financial incentives. I lecture around the world on this topic, and there are lots of people come up to me afterwards, having sat in a room, and I've been hated in person, which is sort of fun, and they come up to me afterwards and they say, "You're right, but we can't talk about that." So I'm not at all clear how big a consensus there really is. The Declaration of Istanbul, which I mentioned, is a big consensus conference. But everyone who was invited has published on these things extensively, and everyone knew in advance what they would say. As a result, I wasn't invited. James Stacey Taylor wasn't invited. Benjamin Hippen wasn't invited. A whole bunch of us who were in favor of these things weren't invited. Well, because we published on these things also, and everyone knew we would destroy the consensus. This is what we do. The third is I will enforce a very important point that you made, because a rich set of interesting comments. I'm very disturbed with the idea of first-person consent at the DMV. It's just strange. We talk a lot in medicine about informed consent, and yet we go down to consent for organ transplantation, which doctors then use to override the family, as you rightly point out, and we get it done by somebody at the DMV who doesn't know anything about transplantation, who says, "Sign here." Next time you do it, ask them questions. I've done it. It's fun. What happens if my wife disagrees? Sign there. What happens if I change my mind? Sign there. What are the risks associated with transplantation? Sign there and go away, right? It's a terrible way of engaging in it. And notice also with regard to things like presumed consent, we're not talking about altruism at all. So it's very important. Thank you.
Response from Dr. Pope-Harmon.
Yes. I would point out that we probably ought to be focusing our attention rather than in what I think would be a pretty small market, to focus instead on two things. One would be means by which we can take advantage of the other 99% of people who pass away in this country, who may have organs that are, for whatever reason, marginal, not used, whatever, and being able to try to find mechanisms by which we can utilize those organs in pursuing scientific advances that may eventually make it so that we don't have to go down the transplant pathway, and in trying to take advantage or alter our approach to first-person consent in a way that allows more people to participate and more people to participate in a meaningful way.
Thank you. Thank you for a rich discussion so far. Now it's my turn to ask some questions, hopefully for some clarity, and then in about 25 minutes it's going to be your turn. So please, again, think of your questions, get them prepared, and try to limit them. Unlike me, I'm going to limit you to 2 minutes for a question. So my first question, Professor Cherry, in one of your papers, again with a wonderful title, Embracing the Commodification of Human Organs, this is a quote. You say, "I argue that human kidneys are, as a matter of fact, commodities. Honestly recognizing and confronting this circumstance will likely lead to greater trust in the transplantation community. Denying that human organs are a commodity, even while treating them as such, encourages the continuation of dishonest public policy tending towards vice rather than virtue." My question to you is, it doesn't seem necessarily so. It doesn't seem necessarily intuitive that putting something in a market will encourage virtue instead of vice. encourage virtue and protect from vice. And I think, in Dr. Pope-Harmon, on your response, I'm asking the inverse of the same. So my question is, how does pretending, in Professor Cherry's word, pretending there's no market when there actually is, and forcing altruism encourage virtue and prevent vice? I'm wondering if we're thinking about the inherency of the system. Professor Cherry.
Sure. First, to the point that organs are in fact commodities, even though we pretend that they're not. And one of the standing arguments is that people say things like, don't commodify organs, don't turn them into just another commodity. The issue, though, is the following. Organs are obviously instrumentally useful things. We know this. We take them out of one person, we put them into another person. That means they're instrumentally useful. It's the definition of it. They're also exchangeable. Again, one more time, we take them out of one person and we put them into another person. All systems of transplantation, including uncompensated organ donation, objectify human organs and treat them as things. That's what we do. They're alienable. That's how we take them from one person again, give them to another. That is to say, they hit the definitions of what it is to be a commodity. At this point, people usually say, but wait a minute, they're of infinite value or something like that. So you can't really talk about them as being a commodity because there's no price limit, But that's, again, to get things a little bit off. The fact that the government says you're not allowed to transfer things except at the price of zero doesn't actually mean they have no price. On the other hand, the fact that something's infinitely valuable doesn't mean you can't sell it. Sometime for fun, because I'm a philosopher, we have odd habits, I every now and then go and look at Christie's and see what they're currently auctioning off. It's fun. And they auction off priceless Monet paintings that are infinitely valuable, and somehow they come up with a price for them. In other words, we can, in fact, give them a market structure. We figure out ways of doing this. With regard to engaging in virtue, if done properly as an open market, not a black market, again, not an illegal market, but an open market, you're asking that these things take place in a very transparent fashion, under the usual structures of informed consent, not that crazy stuff at the DMV, not presumed consent where they just take my organs. I don't know about y'all. I want these things. And insofar as they're worth money, I want to be able to sell them. I like my stock certificates too, and those go to my wife if I die. Not just to the state if it wants to use them. So there are all these different sort of pieces there. Put things in a market, all of a sudden we know what's really going on. We can track things carefully in a way that we surely can do, and we're not lying about the fact that they're commodities when in fact, or that they're not commodities when in fact we're treating them as such.
Well, first thing, I would say that even though there is money exchanged as part of the process of transplantation, we are not here to make money. Maybe there's some hospital administrators here that would say that's not the case, but we're not here to make money. We are here to make something happen to help people, which is a good thing. And I'm afraid if we go down the road of making this into a paid-for thing, it just has no way of being fair. Every person who has a decedent, a loved one who dies, is not going to be able to be compensated for organs because most of those organs aren't going to be able to be used. So some people are going to go without any compensation. It's going to be luck of the draw, which is really unfortunate. And I think that's a bad thing. I think if we start paying some people for organs, that the rest of the world is going to expect to get paid for their organs. It's going to eliminate the altruistic spirit that got things going in the first place and that perpetuates the good that can come out of transplantation. And the last thing is that, and we haven't talked about this yet, and it is a big argument, is that our bodies are a little bit different. We regard our bodies as different. And as such, making pieces of ourselves into something that you can sell is disturbing to a lot of people, myself included.
Let me say real quickly, insofar as you're not here to make money, I run several non-profit corporations. I would be happy to absorb all of your salary beyond base levels of income. Totally happy to do that.
Right. No, my reaction was similar. And we've heard about the 1% to 2%, and I think I reflect sometimes, in world history and worldwide income, are we part of the 2%? I mean, to talk about commodification and the luxury of this beautiful setting is exactly that. It's a luxury. Also, Professor Cherry, you get 2 points marked off for mentioning Mayo instead of the Ohio State.
I was trying to preserve the virtue.
Since the points do matter because there's winners and losers. The next question, first for Dr. Pope-Harmon. As you probably know, the country of Iran actually has a regulated market for organs currently. It's legalized. They have probably around a decade of experience, and there's likely going to be increasing data coming from Iran on the efficacy of this regulated market in their transplant community. And I wonder if it showed that organ donations really went up, that patients like yours their lives were saved, and this really turned out to be a positive thing, do you think you would change your view? For Professor Cherry, you can respond to her comment, but also I wonder, what about Iran? Do you think this is a model for how to regulate? Is this the only model? Do you anticipate good things coming out of those data?
I can say that I wouldn't regard Iran as a bastion of human rights from what I know about them. I would be very concerned that their market would be fraught with the potential for misdirection of organs and duress, placing patients and potential donors under duress for donation. I would really be concerned that there would be the potential for groups that are marginalized or considered to be lesser in stature, women, children, dependent people, that those particular groups would be vulnerable to being forced to donate organs against their will, or to be brought to being convinced in a very unconvincing way. And I'm not sure that Iran could convince me in that particular society. If it were done in a place where I could be sure that things would be above board and that the human rights were observed and that everything was transparent, then maybe I could be convinced.
Okay. Professor Cherry?
My suggestion is look for good ideas anywhere you can find them. One of the interesting things about Iran, I don't know how many of you are familiar with what they did, is they created a market in organ. Well, sort of. What they did was that they created financial incentives for kidney transplant, kidney donation. What they engaged in is surely governmentally controlled, so it's not as if it's an open, free market such as one might prefer. But instead, what they did was they began to offer financial incentives for individuals to donate kidneys. You get a single payment from the government. You can also get a secondary payment from the recipient. And if the recipient is too poor to offer a secondary payment, then there are charitable organizations that will often help come up with an additional payment. What's very interesting about it is they have flipped the waiting list. Instead of there being a waiting list of people to receive a kidney, there's a waiting list of people to donate a kidney. Which is fascinating. Now, have they solved all the problems? Surely not. That's easy. But what they have shown is that financial incentives do, in fact, work. Maybe what we'd like to have is the individuals be compensated at a higher rate. Maybe what we'd like to have is the individuals to receive compensation, which isn't just cash, but maybe it's a college scholarship, or maybe it's some other valuable compensation. What's nice is it's now done openly. They're tracking the data, and they're publishing the data. And so we can actually see what's happening. And in fact, as I've said, has flipped the transplant waiting list. It's remarkably fascinating. So I think take good ideas wherever you can find them and improve on them.
Can I add a little slight rebuttal? That model, I can only think, would only work in a poverty-stricken nation that has been subject to sanctions for years, and in which patients or potential donors have no opportunity for financial gain aside from something like donating a kidney.
So let's try it in the United States. Let's pick something very positive in terms of incentives. If you all find cash to be problematic, pick something else that you find important and valuable. Treat it like a life insurance plan like I've discussed, or like a college scholarship, or some seed money to start a small business or something like this, and let's have a trial project. Let's see what happens. Will it work? Why not try it? If it's, because it may in fact work very well here. We aren't trying it. That's problematic.
Excellent lead into my next question. Professor Cherry, if the utility, because you're saying try it, let's have an experimentation. If the utility or the consequences don't pan out, if it doesn't increase donations, save lives, etc., are you still in favor of inducements, incentives, and other compensation for organs? And Dr. Pope-Harmon, in addition to responding to what he says, or do you think it's inherently wrong? I mean, so if another system outside of Iran, who's doing some things good but also has problems, if another system proved that it was effective, would you change your view, or do you think it's inherently wrong, and why?
Professor Nash is trying to sucker me into saying something I shouldn't, so I'm going to be cautious. I'm not a utilitarian. I actually think the consequentialist arguments work in my favor also. And in fact, Peter Singer, a very famous utilitarian of whom I have great arguments with, has shifted sides. He now agrees with me, where in the past he thought I was just wrong. I had dinner with him at Princeton last fall, and he said, I now think you're right. I think consequentially it'll all work. But as a matter of fact, my view is that we have authority over our own bodies. I recognize the body is different. I understand it may be different from other kinds of property. That still doesn't tell us that it belongs to the state. Recognize the laws that we have now state that it is that your organs are a public resource to be used for public goods, not private gains. Now, last I looked, these are mine. And if anything's mine, these are mine. Or maybe they're my wife's. I don't know. We have to think about how these family structures work. But they surely don't belong to the state. Even in Texas, I won't let the state own them. I mean, wow. So this idea that there's somehow these public resources that we should distribute strikes me as just totally counterintuitive. So as a result, even though I really do think the consequences will work out as I've described, I think individuals, in fact, have the authority over themselves to engage in risky activities. I will not ask for a show of hands. My students have tattoos. That's risky. My students do crazy things like jump out of perfectly good working airplanes in the great hopes that that thing on their back will open into a parachute. Some of my students join the military and go off and spend multiple years in interesting parts of the world where people shoot at them and then come back to me and talk philosophy. It's very interesting. We're allowed to some of my students, again, will not ask for names, engage in all kinds of promiscuous sex. Sometimes for fun. Go to the Centers for Disease Control. Go to their listing of sexually transmitted diseases and read it out loud to your friends. It's a scary thought. In other words, we're allowed to set ourselves, our bodies, our lives, our health at risk for all kinds of things. Patriotism, money, sexual promiscuity. Why can't we set our lives at risk a little bit for organ transplantation when in fact we're doing it for free already? Why not? And if we're talking about cadaver organs, no one's life is being set at risk.
Okay, first, the government has been asked, more or less. We have, as a society, agreed to have them set up a mechanism to be able to provide organs or distribute organs for the better good. We have asked them to do that. We have agreed as a society to do that. They don't own our organs, aside from in the situation that I mentioned, where they are willed our organs, admittedly without greatly informed consent, unfortunately. So your organs are your own. And I just can't help but feel that taking something from your intact body in order to be able to be compensated from a monetary standpoint is wrong. It just feels wrong, and I don't expect that anyone would be motivated to do it unless they were under some sort of significantly difficult circumstances financially or other duress.
Thank you. So this is a long question. First for Dr. Pope-Harmon, then a related question to Professor Cherry. Dr. Pope-Harmon, I'm going to state something the way Professor Cherry does in his writing. So I'm going to say, you are going to represent the current policy and the current transplant community. And I ask, are you exploiting the poor by not allowing them to make money and forcing them into an altruistic relationship while others profit? And doesn't the current system exploit those that die and their family, all in order to comfort the conscience of some policymakers and advisors? Professor Cherry in his work, when challenged by exploitation, flips it on its head and says, well, aren't we exploiting the poor by not allowing them to bring money, the thing that they need? And aren't we exploiting those that die or those that want to procure in order to satisfy ours, the elite's, conscience? Professor Cherry, now that I've mentioned your turn, beyond that reversal of exploitation, there is a real concern over vulnerable populations that's often used. So taking away the simple logical reversal for rhetoric, how would we really deal with protecting vulnerable populations from being coerced, deceived, etc.?
So are we exploiting the poor? I think I explained that earlier, I believe. And that is that in situations, we don't have Iran back yet, but in situations where they've studied this before, the poor are no better off than they were before they sold an organ. They are financially no better off, they are health-wise no better off, they don't have their debts paid off, they're below the poverty line, they are no better off. So I think that is the ultimate exploitation. That is the vulnerable population that we would expect that with just a minimal investment of cash, that they're going to be willing to give up something that's a valuable part of their bodies and may make them worse afterwards. So I don't believe we're exploiting the poor not to give them that opportunity. Other opportunities, maybe. Exploiting the dead, also, no. I mean, the dead are not going to be using those organs. I think if it can be brought to, if something bad like that happening, which happens to all of us, I guess, can be brought to the greater good, and then it's not an exploitation. Any kidneys would go into the ground. It's probably a good thing that they can be used and to bring some good.
I think it's a very challenging question on multiple levels. First of all, we have to figure out who actually is vulnerable. So let's imagine the following. Let's imagine, you all see Professor Nash over there. He's a wealthy physician. Look at him. Everyone look in his direction. Make him feel nervous. Okay? See? It works. See? So he's a wealthy physician. Now, I'm a poor philosophy professor. Okay, so let's imagine I'm right out of graduate school in philosophy. They don't pay philosophy professors the way they pay certain physicians. And imagine I've just started at my university and I really am not getting paid very much. I'm going to try to figure out how to save money, maybe put my kids through at a private school, things like this. And I go up to him, and I get to know him, I discover one of maybe his wife needs a kidney transplant. And I say to him, I'd really like to save your wife. Seems like a nice lady. What I'd really like is first some cash. Notice what I have done. He's vulnerable. I've exploited him. Now, imagine someone even poorer than a philosophy professor. Imagine somebody who is actually quite poor going up and exploiting the wealthy physician so as to save his wife. Now, are you really going to be worried about the poor exploiting the wealthy physician? So you might worry, first of all, what does it mean to exploit and who's vulnerable? I note, for example, that surgeons and doctors in general charge people who are sick. Every time I go to the doctor and I feel horrible, they say, no problem, I can cure you, pay here. Okay? Namely, they exploit the fact of my illness to make money. Now that's interesting. So you have to ask who is in fact exploiting whom. You might also note the following. In places like Texas, the population, at least where I live, the population of the poor, not totally, but predominantly is Hispanic. The Hispanic, because of transplantation, tissue matching, is very likely to donate to another Hispanic. Even so, one of the things that TOSA spends a lot of time trying to educate people is, if you'll donate, we can't guarantee it, but it's very likely to go to another Hispanic because of tissue matching. So there's no reason why those go away on the market either. So you might even be able to keep it within particular communities. Sell it for a lot of money to a wealthy physician, sell it cheaply to somebody with whom you identify.
Thank you. For Professor Cherry, and follow-up just rebuttal for Dr. Pope-Harmon. Who pays for the incentives, inducements, or compensation, and what degree of regulation should practically happen for these payments, and in the current stretching of the U.S. health system, where people are concerned with profit, will this change the profit margin for health systems, insurance companies, and organ transplant teams?
So one thing you might ask is, how much should people be paid? You could leave it totally up to the market, in which case just sort of what the market will bear. There was a study done that was published, a very non-scientific study, that was published, maybe 15 years ago in The Economist, in which they asked students at a large university, kind of like Ohio State, how much would it cost for you, incentivize you to show up to donate a kidney, and it turned out they would do it for about $150. Beer money seemed to work well for undergraduates. Okay. Now, you might think that that's not really an appropriate way of engaging in this, so you might decide what you really want are price controls. I've used the example, so a certain level of income. I've used the example of college scholarships because they're worth a lot of money, and second of all, because they do accrue to the long-term interests of individuals. With regard to who pays, remember we talked about how much it costs to continue to engage in kidney dialysis versus preemptive transplant. It comes out to be about cost neutral after about 12 to 13 months. That is, you save a lot of money by transplanting. So even if you added into that the cost of a college scholarship or some other valuable incentive, you're only looking at a few more months in terms of making it a cost advantage to engage in the financial incentive. As a result, one would easily think that anybody who is currently paying for dialysis would find this to be a positive outcome, looking at long-term costs. So Medicare costs come to mind straight away, and any insurance companies that are engaged in this, because it's financially advantageous.
I could see a scenario, I assume that if this happened, that the cost would be borne by the recipient and mediated or paid by the third-party payers. But I could see a situation where maybe somebody would have kind of cheap insurance, and the third-party payers would say, well, you can have an organ that we can get from an altruistic donor, but you're not allowed to have a donor that we have to, or an organ that comes from a donor that we have to pay for. And I think that would put patients potentially at significant disadvantage if they couldn't afford to have, the really swanky health insurance.
You bring up a marvelous point. It might be that different quality organs will be worth different amounts of money. And that might be useful in terms of shifting individuals' behavior, to incentivize people towards better behavior rather than worse behavior. If I could just figure out how to incentivize my undergraduates to behave in ways that not behave in ways that I know are terrible for their health, that would be a real positive outcome.
Next question. First to Dr. Pope-Harmon, then a follow-up from Professor Cherry. In a Lancet article, editorial, this debate was summed up with this. Ethical arguments have been made for and against the practice, that is, giving inducements or incentives for organ procurement, with the pro side generally contending that legitimizing a market for organs would increase their availability. But human livers and kidneys are not commodities, and hospitals are not just another convenient locale for money to change hands. Trade in human organs is immoral and ought to be outlawed around the world. So my question, is Professor Cherry immoral and ought he be outlawed?
Of course not. He's entitled to his views.
What's that?
He's entitled to his views.
Yeah, sure.
And not immoral.
So one of the questions is, as we think about coming to consensus, I mean, there's often when I read the con, those that are opposed to this, it's often a marginalization such as this, that it's saying it's immoral as a statement. But the morality is not based on which morality. We have two people on here in a discussion that both are really concerned about things moral, things ethical, but they have differing views. So I wonder which morality are people like the Lancet in the consensus statement from the Declaration of Istanbul turning to? And I'll give a follow-up, easier question. Why is there no market now? I guess for Professor Cherry specifically. But for the first question, I think, what morality is the basis, do you think, that brings this sentiment?
First thing I'll do is respond to, because he's yanking my chain again. You understood that he was up to that. That's one of my favorite quotes from the Lancet that he read. And the reason I find it so humorous, that particular quote, is it says things like, hospitals are not just another convenient locale for money to change hands. Now, my wife this last year had heart surgery. It was $100,000. Evidently, there was a lot of money that changed hands in the hospital. Now, when people are honest about that, what we're doing is pretending one thing, but in fact doing something else. I'm not suggesting that doctors and nurses and surgeons and other healthcare professionals are just money grubbing. That's crazy. I want them to have appropriate incentives to do a really good job. Look, I'm a mercenary philosopher. I do this for money, right? And I don't think it's a problem. I think it's a good thing to engage in. So when I suggest that medicine is a commodity, I actually think that's a positive good. I want people to have a focus on what they're engaged in to do it really well. And that matters. Some people have a focus on civic mindedness and altruism. Others are more interested in engaging in things if you add a financial incentive to it. You might think, and you look at medicine, how many of the medical students are going into family practice versus how many are going into other areas of medicine that pay a whole lot more. And then ask yourself the following question. Are they being incentivized towards other areas of medicine that compensate much greater? With regard to the question about the market and the morality, we don't agree on one morality. We don't agree on one way of thinking about the body or one way of thinking about ethics. I've never been at all sure who was the we that asked the federal government to do this in a particular way. They surely didn't ask me. And some of the people who gave the initial testimony, including individuals like Robert Veach, who was the former head of the Kennedy Institute for Ethics, has also changed his mind. He gave testimony initially against a market in organs, against financial incentives. They set the policy based on, in part, his testimony, and more recently, he's come out in favor of certain types of incentives. He doesn't want a free market, but he does want incentives to really help bring more organs into the market. He wants it very constrained, but he has very much changed his position.
Well, I think the moral argument that's usually offered from my end is that it is not a moral thing to do with a human body. And I don't even know that you need to necessarily make the argument based on that. It's just that it's not going to work. It's not going to do what you want it to do. It's going to make poorer people poorer. It's not going to give you a lot more organs, and it's going to potentially make the people that are donating now, the altruistic donors, not want to donate anymore. It's not likely to work.
It is now your turn. So please come to a microphone. You can stand in line. I'll get to all of you. We have plenty of time. Keep your comments to less than 2 minutes, please. And we will have some responses. And you can direct your questions to one person, and we'll let the other person respond briefly. Please, ladies first.
Allie Massoff with the Department of Philosophy.
Get closer to the microphone.
Oh, sorry. Hello. Hi. I have a question for Dr. Cherry. One of the core ideas in your argument is that we have moral authority over our body. And it sounds, thank you, sounds a lot like you're purporting a kind of view of self-ownership. So one question I have for you is that you're talking primarily about redundant organs. But if we own our bodies, it seems like we should be in principle able to sell non-redundant organs like our heart, things like that. Are you in principle opposed to the sale of non-redundant organs? Is it restricted to redundant organs? I'd like some clarification on that.
Sure. I'm from Texas. In Texas, we understand that you're free to do things which are, in fact, probably self-damning. So while I would understand you're free to commit suicide, I would still say you're probably likely to usher yourself into the presence of the Almighty uninvited. Which is to say, I would hold it to be a bad thing for you to do, to sell your heart while living. Makes sense. Do I think the state has the legitimate authority to really impose that on us? No, but I don't think people should do it. Does that make sense? Okay. So I think the way to sort of lay out issues with regard to organ markets, or at least financial incentives, however one wants to phrase that, is to look at redundant organs while living, so the extra kidney as an example, and to look at the heart with cadaver organs as a way of trying to get at more cadaver organs, incentivizing that. I think it's a much more plausible way of functioning and having it work. Do I think that you can do a self-damning thing? Sure. Do I want you to do it? No. So it's a sort of multi-level issue associated with what I think is good or right or virtuous versus what I think the government in principle has the authority to regulate. Does that make sense? There are all kinds of things people do to themselves which I wish they would not do to themselves because I think they're self-harming and dangerous. But I don't really want the government regulating the behavior.
I would add as well that your decision isn't going to occur in isolation.
Sure, that's right too.
Yeah, the heart is not going to jump out of your chest, and you're going to put someone in the position of taking out something that's going to kill you. So it has a lot of dimensions that are probably not all government related. So
that's a good point. So just a follow-up to that is you surely have to find a transplant surgeon willing to engage in it, and a hospital willing to participate, and all of the other things. So it may in the end be an impractical thing also. Sure.
Dr. Mokshin.
Yes, thank you. Can you hear me? Mm-hmm. And I will speak in the first stance only because it's one person's opinion. But I say with all humility that it might be shared by other physicians. I am a physician, have practice. I also serve in certain executive positions. I'm offended by the fact that Dr. Cherry's hypothesis that the driver among physicians is money. In 45 years of practice, I've never looked up a patient's payer source. In this institution, none of the physicians, including administration, refuse care because of the payer source of the patient. We provide charity care, uncompensated care, and so on and so forth. And I won't dwell on that further. So I found it offensive that while you profess to be a mercenary philosopher, I will never, ever, as long as I carry the title of physician, a mercenary physician. I wish you can respond to that further if you wish, Professor Cherry. I will not be a mercenary physician. Secondly, I think your hypothesis that money is an important driver in human behavior, incentive you call it, is fallacious. There's a quote circulating in the hallways of this institution that's arguably attributed to me. At the end of the day, the thing that has given me greatest satisfaction is not how much money I made, but whether I was able to help someone. That is indeed the spiritual heart and brain driver that makes me want to get up the next morning. So we should not dismiss altruism as a driver. If you look at the history, and I will only make one reference to history, because I'm most familiar with that, Christianity that has transformed the world and human, it was not driven by mercenary, but rather by feelings and altruism and service towards humanity. So last but not least, while you made reference to the exploitation, I think your hypothesis that market-driven sales of organs will lead to the exploitation of economically underprivileged people. Because if I have a lot of money, I would be disincentivized to donate. Whereas I am poor, I'll be incentivized. While your other references to scholarship, those are all confounders and separate issues we can discuss at another occasion, including the consenting process. Thank you.
Thank you.
I apologize if I'm being very passionate. It's my nature.
It's absolutely marvelous. Let me say three things just very quickly. The first thing is I surely would never suggest, and I hope I didn't suggest, that physicians are only motivated by money. I said I'm a mercenary philosopher. That doesn't mean I don't actually enjoy doing this. It just means this is, in fact, I get paid for doing this. I try to keep my amateur status also, which is to say I do it partly because I love it. So both professional, mercenary, as well as amateur. I presume human motivation is very complex. Second, that money provides an incentive to do things is just empirically the case. If one looks, for example, at the considerable advancements in material well-being and life expectancy, all kinds of commercial products, people are engaged in these things partly because of the profit motive. My brother works for Intel. He's trying to figure out with his company right now how to get the best chips possible into all those little devices you all carry, because he wants his company to be very, very profitable. Now, those little chips have actually been amazingly useful in medicine to do all kinds of diagnostic devices, all kinds of things that we use and we take for granted. Now, they came partly because some scientists wanted to achieve good things. That's true. And they came partly because some people were really altruistically motivated, and that's also true. But they also came out part because some people wanted to make money from it. And there's no reason why we shouldn't put those together. Third, just very quickly, never give up on altruism. I agree totally with the point. Never give up on altruism. The suggestion is add additional motivations. Why not add additional motivations? Maybe we do better. Why limit ourselves to just one set of ways of thinking about things? Add additional pieces.
Please.
I am a little concerned that you, not only would it exploit the poor to incentivize them, as Dr. Machchan say, to donate their organs, I think you're disadvantaging the poor in receiving organs also, if you're going to have a free market for organs. As it is now on the deceased donor wait list, there is nothing there as far as how much this what title the recipient has, how much money they make, anything like that. It totally takes that out of the organ allocation system. Whereas if you're talking a free market for organs, then the poor person is going to be way at the bottom of the line and what type of organ they can afford. There's a difference between trying to get a good quality kidney or a good quality heart or liver or lung or pancreas and having a used car from the corner car lot because that's all you can afford. How would you take away that in your free marketplace?
Sure. I mean, you ask a complex question. It's a very interesting set of motivational issues and question of what would happen empirically. So think of the following sorts of issues. The first is, given the savings on preemptive transplantation, again, just looking at kidneys, relative to other relative to renal dialysis, third-party payers may in the end actually have a great deal of motivation to pay because they'll save money long-term, especially if you're thinking about groups like Medicare. Can I promise the government would do that? Look, I'm from Texas. I don't really trust the government. But one would hope they would see the implications there. The second thing is, insofar as you get more organs into the pool, you remove people from the waiting list faster. And if you remove people from the waiting list quicker, what happens is those who are left in the waiting list are competing amongst fewer people for the available organs. The third thing is there's absolutely no reason to stop asking people to donate altruistically. And recognize much of the living donation which takes place happens amongst whom? Family members. The motivations within families are probably going to stay exactly the same. Love, concern for the other, or fear of family anger if you fail to donate, which we all know takes place. It isn't fully altruistic anyway, just what happens. So those motivations will still be there. The idea is to try to figure out how to incentivize so more people get in, and it may in fact be with regard to accessing organs, the poor be even better off. I'll give you one additional example here. The market doesn't require that you sell. You can still give it away. That there's a market in medicine does not mean people are required to buy and sell medicine. People can give away medicine for free. Unless it's made illegal to do so, you can do so. So again, think of where I live with TOSA, the Texas Organ Sharing Alliance is the UNOS affiliate in Texas where I live. There's a big part of that structure which is Hispanic. That's our population. And one of the real worries we have is trying to figure out how to convince them to be willing to donate because they're worried it will go to the wealthy majority. So I argue in Texas in favor of directed donation. I tell the TOSA, if you can figure out how to do it legally, have the Hispanics donate to other Hispanics. Because it will remove people from the waiting list. It will shorten the waiting list. And it will save lives, reduce human suffering, and actually benefit people. Nice thing about markets is they're very directed. Right? So if you actually had a free market, which we don't, you could really say to Professor Nash, lots of money. To this person, very cheap. And as a result, I can engage in social engagements of one sort or another. I can be market-oriented in the sense of money, or I can be market-oriented in the sense of trying to benefit a particular social enterprise that I really prefer. That's what's nice about these kinds of incentives.
Please.
I'm Danny Ash. I'm a third-year medical student, but my undergraduate background is in economics. And on that basis, I would like to further sharpen the excellent question posed to Dr. Cherry by the previous questioner. It's clear that the sale and purchase of organs will make somebody better. The question is, whom will it make better, and whom will it make worse off? You've talked a lot about autonomy, but autonomy certainly is only one of the several major bioethical principles that we use to guide our decisions when making difficult calls. And two other important ones are beneficence or non-maleficence and justice. And I think your proposed solution, at least insofar as we've heard, has serious problems for both of those principles. So first, the selling of organs. I think your suggestion makes several unsupported assertions, as do many arguments in the Libertarian Project, regarding the behavior of people. It's commonly assumed that people are profit-maximizing automatons, but really, behavioral economics research has shown that people do not behave rationally under stressful conditions. There's a psychologist at MIT named Eldar Shafir who's recently done some work on decision-making under scarcity. And what he's been able to show is that people's cognitive functioning is actually worse when they're faced with a condition of acute scarcity of an important resource. So the obvious implication here is that while you are asserting that a free market would merely allow the actual price of an organ to reflect the implicit price, I think that it would actually, as has been suggested, exploit underprivileged individuals by forcing them to choose between imminent disaster, being kicked out of their apartment or house, or losing the car, or some other outcome which may not in the long run be best for them. So that's a justice problem. Also, there's the problem of buying the organs. I think you've asserted that the inclusion of financial incentives in the organ donation process would bring additional supply into the market, presumably so as to reduce the price so that poor people would be able to access the organ donation system. But there's no proof of that, and I haven't so far heard what you would propose to do should this assertion not pan out. Are we going to say, well, I'm sorry, the free market is the alpha and omega, the arbiter of organ donations, and it has spoken, you don't get an organ. So if you could just respond to those two questions. Thank you.
Let me first begin with the following. I surely think that Beecham and Childress's 4 principles are corrupt. So we can just put that on the table at once. I don't have any idea what beneficence means for you. I know it means for me. I have a pretty good sense, but you and I might have radically different senses of the right, the good, and the virtuous. As a result, I get very worried about people who want to do, who wander around wanting to be beneficent to me, because a lot of things they want to do to me, I don't want done. Okay, so that's the first thing. The second thing with regard to justice, I don't know what justice means either in those senses. So we could be egalitarians, but egalitarians of what? Equal in what sense? When Aristotle thinks about justice and about equality, he says, okay, equals should be treated equally. But what does it mean to be treated equally? Do you treat people equally based on wealth or noble birth, because they're all equal citizens under the law, or because of some other criteria like merit, social merit? He never adds need. Well, so we could add need, because that would be useful to each according to his need, or we could hybrid. We could sort of mix and match things. All of a sudden, I've given you 5 different ways of talking about justice. I could add to that utilitarian, maximize the good justice. I got 6. Then I can add Kantian, I got 7. Oh man, I could go all the way. Man, look, I'm a philosophy professor. This stuff's fun. In the end, I don't know what justice means. And as a result, I find Beecham and Childress really problematic. So that's, I'll just set the record straight there, because you did a nice job of laying that out, and I really appreciate that. And it was fun. It was like I paid you off so I could say nasty things about Beecham and Childress. So very kind of you. The next issue is, I would never presume that individuals are in fact profit-maximizing automatons. Individuals, again, have very complex motivations. The way of talking about the market is a way of trying to think about what it is to take things like moral diversity seriously. So I will, with unblushingness, even though I'm a red-bearded philosophy professor and look very red anyway, talk about a market in religion, which is to say there isn't one religion imposed on us by the government. Instead, different individuals get to make choices about where they go to church, what they believe, and who they think God is, how they think God commands, and how they think they'll be judged in the last day. I think that's what we get to do. That doesn't mean I think there isn't one right religion, because I do, but it does mean that I think that there's a market of ideas out there to try to get people to make choices. So take it from market and religions and think of a marketplace in moralities. Right? So you have different ways of trying to think of moral goods, different ways of talking about justice, different ways of talking about the good, different ways of talking about beneficence, and even different ways of talking about autonomy, because there's not one way of talking about autonomy. There's lots of different ways. Think of the market as being about the protection of families. You protect your family your way, I'll protect my family my way, given different moral understandings. Think of the market as being about the education of children, the competition amongst charities. Think of it as about different worldviews. A lot of my students are animal rights activists. I wear leather boots and a leather belt, and I have a t-shirt that says, "Meat is murder, tasty, tasty murder." And I have another t-shirt that shows a batch of bears eating a human. And it says, "The family that prays together stays together." Okay. And I let my 16-year-old son wear that shirt to school. And when the principal called home, I said, "Family values." He didn't know how to respond. This is, so in other words, there are all these different ways of trying to think about worldviews. What's nice about things like market structures is it does not require that we all share one moral view of the right, the good, and the virtuous. All it requires is that we agree to get along. Next, real quickly, thinking in terms of how you're worrying about things like how you worry, all the worries about exploitation of the poor and so forth. There's a reason for thinking about different types of incentives. If you're really worried that what the poor will do is take the money and go blow it, okay, then I would suggest don't give them cash. Give them something that they won't blow, a college scholarship. They use it or they don't use it, but at least they don't destroy it. That's what's so nice about my university and its very expensive policy of providing college scholarships to every person who works there and all their kids. Because it means that people who are very impoverished take jobs there, knowing full well their kids will be better off long term. That's really powerful. That's an immense incentive to work at my university instead of that lesser university which we will refer to as University of Texas, which is just north of me. I mean, they have, 88,000 students. We have about 5,000. I think there's a good reason to work for us, not for them. That's an incentive. It's not just market, it's not just money, it's about their children and their long-term financial future of their kids, the opportunities to make choices, the opportunities to really flourish. That's not just about money, that's about human well-being. That's powerful. So think in all of these different kinds of levels. Marvelous, rich question. Thank you so much.
We have I'm going to take liberty and take 5 to 7 more minutes, so let's make questions quick and responses quick, and please.
Thank you for the debate. Is this on? Very, very intelligent comments, great information. My name is Ken Tolloway. I'm CEO of Lifeline of Ohio, which is the OPO for the greater part of the state, and president-elect for the Association for Organ Procurement Organizations. So I'd like to point out some details and then some observation and then ask whether or not you feel it's appropriate. First, some details. So when donation occurs, it can occur in such a way when there's living donation that there is informed consent, and there needs to be informed consent. When donation occurs after someone has died, and this is in association with a registered donation, the word consent is not in any state uniform anatomical gift language. The word is authorization. It's authorization for a gift after you're dead and there's no further use for that gift. So the gifts that we help allocate are actually that. We're in charge of the disposition of that gift. So what's happening in this country, that fine, bright line that was put in law 30 years ago, National Organ Transplant Act, said that there'll be no valuable consideration. So what's happening now is, Amy, you mentioned that there's funds available for living donors who actually have a need and can demonstrate a need, and that's a fairly funded project. And there's also, the state of Ohio has a law that allows you to take tax deductions up to $10,000 for non-reimbursable costs for any living donation expense. but there's nothing on the deceased donor side. So we have, first of all, one's informed consent and very much different than a gift of your remains once you're declared dead. It seems like what we have going in this country is, a practice that's varying in those two situations. So, do you agree? And is that appropriate?
No, I should have used the correct terminology, using the terminology authorization rather than consent, because it really isn't, and we understand that it doesn't meet meet the standards of a consent. That said, I do think there's still a lot of misconception about what actually happens and what you're signing up for when you do that in the BMV, and that probably as a transplant community that's an area that we could focus on. And actually, if anything, rather than decreasing the number of potential donors, I think an educational effort that would be focused on that would probably increase the number of available donors. That plus efforts to have more expedient ways of opting in, et cetera, that we were talking about a little bit before the debate started.
The only thing I'll add to that is it's a funny kind of a gift when the government says you have to do it for zero. So the organs are actually worth a lot when I die, assuming anything's still useful. My organs are actually worth quite a lot. When the government legislates that the only way I can transfer them is at a cost of zero, it's a funny kind of a gift. Because we all know how very, very valuable they are. And it seems to me, insofar as I care about my stock certificates, I also care about my internal organs, and I care about my wife a lot, and my children a lot, and I'd really like it if they benefited from it. I'm happy to help others also, but it would really be nice if I knew I would be able to take care of my loved ones and the things I really care about.
Thank you. I'll make a quick comment also. I mean, the distinction between authorization and consent, I mean, most law around organ procurement is centered around a state law, around property. And in some ways it proves Professor Cherry's commodification, one of his points. But that can change. I mean, legislation could change. And I'm of the opinion that it probably should be, that as a medical community, we have a standard of informed consent. I'd like to see that used in organ procurement as well. Next question. We have two more questions.
Yes, my name is Timothy Denny, and my question is for Dr. Cherry. I have very little of pre-med and all that, but my substantial undergrad coursework involves dealing with health literacy, specifically among people of lower socioeconomic status, such as recently arrived immigrants and all that. I've been doing this now for approximately about a year and a half now and one of the major challenges that many recently faced immigrants have is that they, besides the language barriers, is also dealing with what they feel is the persecution by armed authorities, as well as job discrimination, among other things. Going back on the concept of doing an informed consent, along with financial incentives, requires that the person have a fully understanding of what's currently going on. And yet, at least what the coursework though is with the usage of market outcomes, is not everyone can actually participate in the markets, as well as the markets actually failing, such as the near collapse of the fishing market during the 1990s, which forced government intervention, or such as the collapse of the housing bubble back in 2008, which forced government intervention, which during that collapse disproportionately tend to hit people who came from a lower socioeconomic status, as well as immigrant status. Personally, several people who I've worked with over the past year were either evicted or came very close to being evicted because of problems with the mortgages on factors in which they did not consequently understand. Going on with on a matter such as going on with just a mortgage, but obviously organ donation, I would assume, is a more personal affair, one that would require a more informed consent. May I ask is that what how would you actually recommend stuff that's how we can introduce like policies to make sure that people, ISIS, can actually participate in such a market-based orientation?
Thank you.
Again, rich set of issues which I can only briefly touch on given time. The first is it's very puzzling and it's quite interesting. There's a nice book by Margaret Radin, the title of which has escaped me at the moment. The last name is R-A-D-I-N, in which she puzzles about the way in which we think of the poor as being unfree with regard to commercial transactions. She says this is odd. There's something odd about the fact that we think it's totally fine for the middle class and the wealthy to engage in commercial transactions, but we think somehow the poor are being exploited when we do that, even though it's exactly the same activities. That the poor are less free with regard to certain activities, which is true, don't have as much money, doesn't actually mean they don't make free choices. And it doesn't actually mean that they aren't smart enough to make intelligent decisions on their own best interests. Often they're constrained. So think of the nice example of immigrants. What's very interesting, because I work in a community which is very much structured with lots of immigrants from the Arab world, from Eritrea and others, and one of the things we work very hard on is things like the language barrier, things like making sure you actually get informed consent. One of the interesting things there also is that informed consent, these barriers we're talking about, don't pay attention to commodification at all. They're about getting consent for transplantation altogether. The transplantation community has to figure out how to work very hard to get proper consent from individuals, even for donation. Right? The addition of money doesn't change that. That's the issue with regard to informed consent just doesn't track commodification versus non-commodification. It tracks this idea of getting real authority. So I recommend Margaret Radin's book to you and the real issues, as you rightly point out, with regard to making sure people get really good education with regard to what they're in fact engaged in.
Okay, well, thank you very much.
Thank you. And last question. I invite you to vote on the new poll, and then we'll declare a winner and give applause afterwards. So, last question.
My name is Marilyn. I'm a post-transplant coordinator for the Ohio State University Wexner Medical Center. I just want to thank you for saving me from another evening of Candy Crush. And I would also like to let you know that I've raised 1 son and 5 daughters, so I'm all about commodification of everything, almost. The problem here, from my point of view, is that I can't take the organ back. You know, I've gone through prom dresses and homecoming court things and all kinds of tennis rackets, but I could always take them back. I can't go get a manufactured kidney or a liver or anything that's a standard organ or a standard of care in that sense. Also, I kind of agree with Diane that it kind of exploits the poor on the converse side, where they're not in a position to bargain for their organs. And I don't know what insurance company is going to incentivize the commodification by offering $10,000 or $20,000 scholarship, because the insurance companies are going to find a way on the other end to penalize the donor if it doesn't suit them. So I would just like to hear your comments on that. There's just no way to standardize. And you're opening up a whole new level of legals. Attorneys are going to be in the middle of, hey, I want to take that organ back, or that organ wasn't good enough. I just see a whole big world of muck coming out.
The classic attorney article, argument. Don't let the attorneys get involved, please.
He's tempting me again. What I'll note, first of all, is that you can't take back donated organs either. And that's a problem with donation, period. It's not really about commodification, it's really about the process of donation. But I think you're right to worry about it. The second issue is it doesn't really touch on deceased donors, because insofar as we're willing to take organs from deceased donors, which I presume we'll still be willing to do, giving the family money for that won't, in the end, won't be nearly as, I mean, it's the same issue with regard to donation. So as a result, you might not be that worried about those kinds of issues in those cases. With regard to insurance companies, hard to know what they're willing to pay for. I'll grant that point instantaneously. So that's what makes Medicare so interesting, because Medicare actually pays for a very large amount of kidney dialysis and a very large amount of organ transplants, and they're tracking comparative data. And so we might actually be able to incentivize it through that system in a way that practically we would have difficulties with the insurance companies. It's an empirical question, I'll grant that at once, but it's very interesting looking at the Medicare data and how quickly you actually come out cost-effective by doing the transplant.
In honor of Dr. Mokshan's decades of service and that I bear his name in my position, please.
Thank you for indulging me, but I would like to make an invitation to Dr. Cherry. And not only a personal invitation, but also as a proposal for us. Invite you to come with Dr. Amy Pope-Harmon, Dr. Nash, myself, our medical students, to make rounds with our patients. I think the depth of our understanding of some of their drivers, incentives, and all the things you talked about will be much enriched for both of us.
In part of my training, I was at Rice University, but at the time I was there, Rice University had a cooperative program with Baylor College of Medicine. And the professor, who was my doctor father, has an MD and a PhD, and he did exactly what you suggested. He dragged me on all the rounds at all the early in the morning, late at night. So we used to do rounds weekly in the medical ICU. We did all kinds of patient rounds, and I surely have seen the depth of real motivations and the real complicated issues with regard to patients. I have immense appreciation for everything, in fact, that you do. I've seen it firsthand. Immense appreciation for it. Thank you so much.
Well, let's give a hand for our participants.
That was fun. Answer more questions.
Really, excellent discussion, and thank you again to the Benjamin Rush Institute and for all the students and their energy and zeal. And thank you for those who endured. I think our attrition rate was only about 20. So if you haven't voted, please vote now.
It started over, did it?
And we have, I will declare, I don't know how much of this is lost by attrition, but I have to declare Dr. Pope-Harmon as the victor of our debate. Thank you.